Gentle disclaimer to all of our listeners. All medical information mentioned in this podcast is purely informational. It is not individualized medical advice. Please follow up with your physician or medical practitioner for individualized care specific to your needs. Thank you.
Hello, everyone, and welcome to the Know and Do Better podcast. I'm excited for this episode because today we will be discussing questions to ask before surgery. And we have Dr. Jeffrey Schildhorn here with us. He's an orthopedic surgeon. Thank you so much for joining me, Dr. Schildhorn.
Thank you for having me.
So for those who don't know Dr. Schildhorn, he graduated from Duke University and attended medical school at Temple University. Focusing on minimally invasive surgical intervention, Dr. Schildhorn relies on arthroscopic procedures when possible in order to cut down on downtime following surgery. Dr. Schildhorn was born in Philadelphia, but later gained hands-on experience in surgical intervention and sports medicine on the West Coast. Although he is an expert in orthopedic surgery, Dr. Schildhorn is known for taking a more conservative approach to orthopedic medicine and recognizes that many patients do not need to undergo surgery. In fact, it has been found that many patients can often return to normal function through careful planning and other means such as physical therapy or minimally invasive procedures. For myself, at our physical therapy and Pilates practice, we see many patients with different musculoskeletal conditions, and as they come in, and many of the complaints are osteoarthritis and different joint-related conditions. And they often ask, do you think I should get a joint replacement? What is that going to be like? How do I decide? So, Dr. Schildhorn, can you take us through that process when you're consulting with patients who are considering joint replacements?
Yes, I absolutely can. I perform 3 different types of joint replacement. I do the shoulder, hip, and the knee. And by far the most common internationally is the knee, followed by the hip, followed by the shoulder. There are others, but they're far less frequent. I think that the criteria for when a patient needs a joint replacement is highly variable among doctors. But for me, the most important feature is that the arthritis is very advanced. And what arthritis really is a degenerative condition of articular cartilage, or the cartilage that lines the bones of the joint. And for me, as I was taught in my training and I've continued in my practice, for a patient, they really should be highly symptomatic. In other words, their pain should be quite intense, inhibiting them from various activities of daily living and from sports and from sleep and all the things that keep them happy. But also their x-rays and their scanning should show that they really don't have any cartilage remaining. And for patients that meet those criteria, a joint replacement is highly valuable.
And so what factors would make someone not a good fit for a joint replacement?
Well, I think if patients' expectations are not in line with possibilities that are attributable to joint replacement, i.e. they are expecting to be running marathons afterwards after a total knee or total hip, you can, but it's a mechanical part. And mechanical parts like brake pads or tires do tend to wear out over time. And so that's not really the ideal reason to do a joint replacement. It's important to return to function, but returning to competitive tennis or competitive running aren't applicable for all patients. Now, if you're a professional athlete and you've developed arthritis, maybe for that person, but not for everybody. Additionally, patients really have to have an overall quality of life that is commensurate with having a joint replacement. So when somebody is very much overweight or isn't healthy, has diabetes, is not controlling their sugar levels, the complication rate does go up significantly, and complications of joint replacements can be very serious. So we try to encourage patients to maximize their health for performing operations like these.
Right. And I know that many of our patients, they will sometimes come to us for preoperative physical therapy. And so I know that that's one of the things that can help set them up for success as well, right? For better
I completely agree with that. Yeah. Strengthening around joints, which is very hard to do when the joints are disabled, when they're in pain.
Yeah.
It's difficult, but very important. I think getting a head start before a joint replacement is critical.
At Inspira, we see many people who have hypermobility and EDS, many of whom have recurrent shoulder dislocations. What's your experience with individuals who are hypermobile, have EDS, and their success with surgery to prevent dislocations?
That's a very good question. We tend to rely, and I say we being the orthopedic surgery community, tend to rely much more on physical therapy for those patients rather than surgical management. And the reason for that is that the tissues, they're not changed with surgery. We can put in a joint replacement or tighten the tissue surgically, but they tend to stretch out over time.
Right.
So for a patient with multidirectional instability of the shoulder or the hip, even the knee, we can tighten it up very much, but it tends to loosen again over time. So having secondary stabilizers in the form of the muscles around the joint, which can be completely adequately stabilized with physical therapy and strengthened with physical therapy, is how we approach those problems. In fact, the number 1, 2, 3, and 4, and 5 treatments for problems like that are physical therapy. And then if all else fails, surgery can be considered.
Yeah. We have seen some of our patients who have had different kinds of surgeries who have hypermobility, and it seems that it might be temporary if and or not give them too much relief. And so we do lots of exercise with them. So moving into trauma surgeries, how does that consideration, or like how does that differ from someone who's choosing to have a joint replacement?
Well, trauma surgeries, I usually see patients come into the emergency room or into my office with a stable fracture. We treat lots of different injuries. People in New York, including tourists, like the ice skating rink. They go out of town to ski. They play competitive sports in group settings. And there are also non-traumatic injuries, sort of overuse injuries. But trauma injuries are usually very clear whether they need to be fixed or they don't.
Right.
And joint replacement, it's a much longer process that starts at a certain point, whether it's from an injury or just from overuse over time, or even genetically. Some people are predisposed to cartilage wear and tear. But trauma is much more clear. If someone has a very distinct fracture pattern of the ankle or the wrist or the knee, in order to return them to adequate function, surgery is almost always required.
Right.
There are some injuries that can be treated without surgery. We call that closed management. And in those situations, the results are just as good with surgery or even better. So we avoid it. But it's quite clear when you see an X-ray of a patient who sustained an injury, whether or not they require an operation.
Gotcha. And so what are some of the situations where you would recommend against surgery and instead refer them to PT or pain management?
In a trauma setting?
I guess in all settings.
Well, I send almost all of my joint replacement candidates to physical therapy before surgery, unless they have already had multiple rounds of physical therapy or they've been living with their disease for many years and have just come to the end of the line. In those situations, I will offer someone surgery without physical therapy. But for patients who are not quite clear, or it's the first time hearing that they have significant arthritis, inevitably send them to physical therapy to see just how much we can get out of it. Because sometimes you can live for quite a long time, even with a significant arthritic problem.
We see that a lot with the patients who come in for physical therapy. They're wanting to just put off surgery, and some of them can do it for quite a long time. There comes a moment where they need to make the decision. So
I think patients do very well with surgery after they've exhausted all their options. And I think that part of that is psychological and part of it is physical. The psychological aspect is they're ready and they are willing to put the energy and time into it. And they don't really have any second thoughts. I think that that's a very important aspect to waiting until it's time.
Yeah, definitely. What can patients do to set themselves up for success prior to surgery besides doing the preoperative physical therapy, I guess maybe some coaching so that they're in the right mindset, or what would you recommend?
So the prehab that you reference is very important. If a patient is struggling with metabolic problems like diabetes or glucose control, getting that in line is very important because we want to prevent complications, especially infection. And infection tends to be more common and healing is slower in situations where blood sugar is not controlled very well. Patients who are more overweight than they'd like to be do benefit very significantly from preoperative weight loss. Many patients like to wait until after surgery and think that they're going to do that afterwards, but they do much better if their BMI is lower. Their weight per height, as it's really determined, is lower. And so patients can set themselves up for significant success by maintaining an overall healthy lifestyle and a healthy body before surgery.
Okay, wonderful. Any other recommendations for people who are trying to decide if surgery is right for them and how they can determine the best surgeon for them?
Well, I think you have to have a really good relationship with your surgeon because the process of going through surgery with anybody is a team effort, and you have to feel confident in the person that's working with you to be comfortable with you too. The patient is a vital part of the process, and you put in these these joint replacements or perform any of these operations. And that's a one-day affair. It takes an hour or two in most cases, and the rest of it is really up to the patient to maintain control of the situation afterwards by going to their physical therapy, coming to all of their postoperative appointments, following the instructions that are provided, and not becoming discouraged as well, because it's a long haul. I've had surgery on 2 different areas of my body, and I've had to go through a lot of convalescence and rehabilitation, and I can tell you it's a bear, but getting through it with the help of a team is important, and I think the patient is the biggest part of that team.
Absolutely. Well, thank you so much for this. I want to encourage all of the listeners to check out the resources that we have listed in our bio. We will have Dr. Schildhorn's contact information. And if you have any other questions and concerns, you can reach out to him directly. Dr. Schildhorn, thank you so much for your time. I really appreciate it. And everyone, tune in next time for another informative chat. Thank you.
Thank you very much.